Lithium-induced nephropathy. Definition. Lithium has been the most effective psychopharmacological drug in the long-term treatment of the patients with recurrent unipolar and bipolar affective disease. As a result of its widespread and prolonged use in patients with recurrent affective disorders, psychiatrists are increasingly aware of the full spectrum of possible side effects of lithium. One of the side effects associated with its chronic use is lithium-induced nephropathy.
Hi friends, today we will talk about lithium. Lithium is an anti-manic drug. That is, it is used mainly in mania and bipolar disorder. Lithium is a small monovalent cation and is handled by the kidneys in the same way as sodium. So how does it act? Lithium mainly inhibits the breakdown of inositol monophosphate to inositol. This results in a decrease and subsequently a decrease of PIP2. PIP2, as we know, is the precursor of second messengers IP3 and DAG in the cell membrane. These second messengers are responsible for various effects. Now, PIP2 dependent pathways are thought to be increased in mania. So, treatment with lithium is expected to decrease the activity in these pathways and provide relief in mania. Let us now move on to the pharmacokinetics of lithium. Quite interesting.
An example of a relatively unique diagnosis, but one that I think may allow you to make a very specific diagnosis in a certain subset of patients. Now, as you can see on these T1 post-SCAD and T2 weighted images, there are innumerable tiny cysts scattered throughout both kidneys. Now, interestingly, notice how these aren't within all of the renal parenchyma, but rather all of these little tiny cysts, which measure 5 or 6 millimeters in size, are all clustered right at the renal cortex. This was actually a patient who had a very unique history. This patient had a history of chronic lithium use for a psychiatric disorder and had known lithium nephropathy. And this is exactly how they can look. Classic lithium nephropathy, whether on CT or MRI, will present with innumerable tiny cysts along the renal cortex, right at the surface of the kidney. If you see that, the first thing you've got to do is look into the patient's medical record, see if there's any history of lithium use, and if there is, you can make the diagnosis of lithium nephropathy.
Applications in nursing. Renal function should be carefully evaluated in all patients for whom lithium is considered as viable treatment option and before starting treatment. In a hospital setting, the measurement of creatinine clearance is recommended since it generally accurately reflects the glomerular filtration rate, and full 24-hour urine collection is possible.
And I'm a psychiatrist at Mayo Clinic. We get a lot of questions posed to us by patients and by clinicians who refer to the Mayo Clinic Depression Center on how best to optimize lithium treatment. It's a great question. Lithium is a mainstay for treatment in bipolar disorder, as well as really augmenting antidepressants for major depressive disorder. Quite frequently, we get this question about how best to use lithium and what happens when we see these minor fluctuations in thyroid function tests. And again, I would really emphasize minor. These are slight changes in thyroid stimulating hormone, TSH, or slight changes in circulating levels of free thyroxine or free T4. They're changes that are within the range of normal. They're changes that an endocrinologist probably would not make any recommendations to use thyroid hormone. But some of our data from the Depression Center would suggest that low-dose levothyroxine augmentation of lithium may in fact be quite helpful. Case in point was a study that was done really looking at the relationship between mean levels of free thyroxine that we can measure by blood test and measures of mood stability, specifically number of cycling episodes per year and a patient report of depressive symptom severity known as the BDI. And what this data showed, even within the range of normal, that lithium maintained patients with a free T4 that was in the lower range of normal had higher rates of mood cycling and higher rates of depression. Patients with a mean free T4 that was in the upper limit of normal had less cycling, had less patient-report depression. And again, to emphasize, these are thyroid values that are within the range of normal. These are not patients who developed hypothyroidism or subclinical hypothyroidism during lithium treatment, which actually is not an infrequent occurrence. But this data really underscore to us that there may be merit in really making sure that thyroid function is as optimally managed as possible during the course of lithium maintenance treatment, suggesting that there may be utility in looking at low-level thyroid augmentation to keep those mean free T4 levels in the upper limit of normal and a commensurate TSH level that's in the lower limit of normal. This is not making someone hyperthyroid. That is not the goal here. We know that there can be consequences of that from an endocrine or cardiovascular standpoint. But for us at the Mayo Clinic Depression Center, when looking at long-term lithium maintenance, we really look at the potential merit.
Pros and cons. Pros. Lithium has been the most effective psychopharmacological drug in the long-term treatment of patients with recurrent unipolar and bipolar affective disease. It's important to note that stopping lithium can only have beneficial effects on the kidney as long as the creatinine clearance is greater than 40 ml per minute. Cons. One of the side effects associated with its chronic use is lithium-induced nephropathy, which can eventually manifest as terminal kidney disease, which needs dialysis or kidney transplantation. If the creatinine clearance is less than 40 milliliters per minute, the underlying pathology may progress despite the elimination of the toxic trigger compound lithium, with apparent deterioration of renal function at the same rate as before.
Nephropathy. Via the New England Journal of Medicine. A 59-year-old man with a history of bipolar disorder was admitted to the hospital after a fall. He received a diagnosis of multiple fractures of the head and spine. The fractures were managed non-operatively. During the hospitalization, his urine output was noted to range from 4 to 6 liters per day. The patient had taken lithium for 27 years before discontinuing the medication 8 years before the current presentation because of mild hyperparathyroidism and renal insufficiency. Serum creatinine level, 1.5 milligrams per deciliter, 130 milliliter. While he was immobilized in the hospital, his serum sodium levels rose from 138 millimoles per liter to 149 millimoles per liter, with a urine osmolality that was inappropriately low, 262 mg per kilogram. The urine osmolality did not increase with the administration of desmopressin, which confirmed a diagnosis of nephrogenic diabetes insipidus. As part of the evaluation for the fall, computed tomography of the abdomen and pelvis with contrast enhancement was performed, and the results showed numerous small renal cysts in the cortex and medulla of both kidneys, axial, panel A, and coronal, panel B, views, with a non-standard window used to enhance visibility of cysts. Lithium is known to cause tubulointerstitial nephropathy, which may be seen on imaging as multiple small cysts. Management of this patient's condition included a low-salt diet and a liberal intake of fluids. His sodium level normalized, and he was discharged to a rehabilitation facility.
Issue project in Ecuador. The average annual loss of creatinine clearance in patients with induced nephropathy was 2.29 milliliters in minute. Among 24 patients, 12 reached end-stage renal disease at an average age of 65 years. The creatinine clearance in the shunt and in the last follow-up was inversely related to the duration of lithium therapy, both in univariate and multivariate analyses adjusting for age, gender, hypertension, and proteinuria.
Using lithium to treat bipolar disorder could have a bad effect on the kidneys. According to UPI, lithium has been shown to suppress a certain enzyme that protects kidneys from failure. A new study is showing concerns about the commonly used yet seemingly effective tactic. Those who take it at high doses for long periods of time to treat mental health illness may have an enzyme known as GSK3 pushed down to unhealthy levels. That enzyme keeps protein from spilling into the urine and prevents kidney failure.
Conclusion. In conclusion, although lithium remains one of the most effective treatment options in the long-term treatment of patients with recurrent affective disorders, monitoring renal function at the last twice a year is mandatory and should include the evaluation of the glomerular fibrillation rate at 24 hours.